Prynon da a croeso, welcome to our symposium this afternoon. And this is the Health for Health Professionals Wales Symposium. So hopefully everybody who's in here is expecting to hear us talk about what we've been doing over the last many years, actually, from when Health for Health Professionals Wales was first created in 2012 by Debbie Cohen, and also what we've been doing in an expanded service during the COVID-19 crisis. HHP Wales is a free confidential service available to all NHS Wales staff and healthcare students working in NHS Wales. And what we'd like to do today is to share with you a bit about what HHP Wales is, and also cover some important topic areas that have certainly been very much in our minds as a result of the COVID-19 crisis. I'm Jon Bisson. I'm one of the co-directors of HHP Wales, and I'm a professor in psychiatry and a practicing consultant psychiatrist in Cardiff. One of the things that we're very keen to say is that we're very committed to HHP Wales reaching everybody that's working in the NHS in Wales, and to that end we believe it's really important that we're a bilingual service, that we provide our offerings in both Welsh and in English. And just to emphasise our commitment to that, I'd like to introduce you to Naomi Marfell, who is our senior project manager, who's kindly agreed to say a few words in Welsh just as an introduction and to emphasise our commitment. So Naomi, can I hand over to you?
Diolch John. Pnawn da pawb. Croeso i symposiwm cyntaf Iechyd Iechyd Proffesiynol Cymru. Dwi'n Naomi Marfell o'r un gweithio fel reolwr am y gwasanaeth. Diolch am ymuno heddiw a gobeithio eich bod chi'n mwynhau y siaradau. Diolch, and nôl i John. Back to you, John.
Thank you very much, Naomi. So we've got quite a tight schedule that we're going to aim as hard as we can to keep to this afternoon. And we're absolutely delighted that Frank Atherton, Chief Medical Officer for Wales, has kindly agreed to speak to us today. Frank, as many of you will know, has been the Chief Medical Officer since 2016 now, and brings a wealth really of wisdom and expertise to Wales, not least from his previous work in both Canada and in North Lancashire. I know from having worked with Frank that he's very passionate about the health and well-being of staff in general, and we're absolutely delighted with the support that Frank's offered to HHP Wales for a long time now. So Frank, we're extremely grateful to you for breaking up your busy schedule and your numerous responsibilities to come and speak to us, and I'd like to hand over to you. Thank you.
Yeah, thank you very much, John. Prynon da, good afternoon, everybody. Nice to see such a big audience for this seminar, and a lot of interest here in HHP, which is fantastic. I suppose the starting point, for anything I have to say, has to be, the extraordinary year that we are still in. It's difficult to think back and reflect that a year ago we'd never heard of coronavirus, and for many of us as health professionals, it has, of course, over that year become almost all-consuming. So it's actually quite a pleasure to talk to something which obviously is related to coronavirus today, but which isn't completely about coronavirus. One of the best things for my own mental health is to kind of get away from COVID occasionally and deal with some other issues. So I'm delighted to be here, and thanks John for the invite. I really appreciate that. Look, there's no lack of commitment from Welsh Government to the issue of mental health and well-being, and that's reflected, I think, in the recent appointment of a Minister for Health and Wellbeing. That's Elena Morgan. The First Minister appointed her, and that's a really that really boosts the profile actually of mental health issues across a whole gamut of Welsh policy, which is fantastic. Look, we're entering winter now. We're into winter. We've got Brexit just around the corner, and we've had COVID for the last year, and it's not going away anytime soon. So that is really that adds up to a perfect recipe, perfect storm, if you like, perfect recipe for issues to do with mental health and to do with the front line in particular. And look at what's happened, how magnificently our staff, across the whole of health and social care have risen to the challenge in the last year. We don't have the kind of clap for health professionals that we used to have anymore. But I think, you know, in terms of public recognition of what's going on, that still remains and is a strong feature. The frontline staff in health and social care have done a magnificent job and continue to do that, and we need to support them. And that is absolutely recognised in government. They've been under enormous stress. I've seen it, you know, in colleagues in my own workplace. I've seen it in through the eyes of medical directors in terms of staff that they work with in the NHS. So it is all around us. And I was really pleased at the beginning of the pandemic that we looked at this, and we really only had quite a small investment in HHP, but ministers did readily agree to increase the investment to provide an extra £1 million, over £1 million, into the service, because they recognised that this wasn't just something that was affecting doctors, but something that could impact positively on all healthcare professionals. It's really important that we get that, and I guess you'll be looking you know, today at how we can make sure that it is available to everybody, not just doctors, but nurses, healthcare profession, students from all branches of the profession, paramedics, pharmacists, therapists, dentists, and even including, of course, really importantly, admin staff and clerical staff, you know, who are the backbone of much of what we do as well. So, you know, it's great that we have this service here in Wales, that it's available to all, that it's free at the point of care, as the NHS should be, and that it provides that confidential and completely independent service. So I'm really pleased to see how HHP has developed over the time since, as you rightly say, since Debbie Cohen launched it. I think it was, you know, through Mansell Aylward, you know, was very influential in the inception of HHP as well. So the progress report that HHP, you know, has produced is really helpful, because we always, you know, any sphere of activity in the NHS, we need to document what we do and how effectively we're using resources. And so I've been pleased to see the steady stream of referrals, you know, into the service. And ever since the middle of July, that's been increasing. And also to see the diversity, as I say, you know, it's not just doctors, it's really diversified very well. And I think the empathy and the support that's provided by the staff, you know, is really, really vital to the well-being of our staff here in Wales. So, you know, this has to continue as the pandemic goes on. We've got a little bit of light at the end of the tunnel just last week, you know, with the announcement of vaccination started just this week in Wales. It's early days, of course, that's going to run through into next year. And that gives us some hope for the future. There's a lot of unknowns about vaccination, but we are in this still for the long haul. And so having HHP there to be able to support health and care professionals is going to be a continued need. I think it's fair to say that although, you know, much of my work is about dealing with and trying to prevent immediate harm from coronavirus, not least in terms of deaths, but also in terms of hospital admissions, etc. You know, we do take a very, we do try in government to take a much broader construct of the harms. So we have a 4 harms model. We recognise that mental harm from, you know, the direct effects of coronavirus is really important, but also mental harm from the kind of economic and social circumstances that coronavirus is plunging us into. So this is not, there's no quick fix for this. We will need to carry on. I thought I'd just mention some of the other kind of mental health initiatives that are going on through government, just to flag them, because they're all related really. We do have an in-work support service which provides rapid access, hopefully, to OT, to physiotherapy and psychological services. And that's designed obviously to help you know, employed or self-employed people get back into work when they have significant mental health or musculoskeletal problems in particular. I've seen the service work very well in North Wales and Swansea Bay, and you know, it's rolling out as well into Mid Wales and also to South East Wales. And so we've had additional funding from government, about £250,000 of that. So that's another positive area, I think. We do worry about, you know, about the fact that coronavirus is impeding access to the labour market, not least for, you know, younger people. So the out of work peer mentoring service is quite important in that regard, because it tries to support those who are furthest away from the labour market, who need to get into the labour market, or who need to rebuild their lives and get back into training, education, and thereby into employment. So focusing on those long-term support to people recovering from mental health and substance misuse issues is also important in that regard, getting those people back into into the workforce. We know that work protects health, it protects mental health, and is an enabler overall of health. So again, there's been an increased investment of about £250,000 into that programme. A couple of other programmes, Time to Change Wales, encouraging people in Wales, encouraging workplaces to sign the pledge, the employer pledge, which is a public declaration of the organisation's commitment to challenge mental health stigma, which is still abounding and which we need to always challenge. We can't afford to have discrimination in the workplace, and we need to make sure that workplaces are amenable to the needs of people with physical and with mental health issues. Public Health Wales is doing some good work really around the How Are You Doing campaign that was created to help people to look after their well-being during this particular time, and it provides help and advice on how to keep ourselves both physically and mentally healthy as we suffer the strains that coronavirus is bringing. So that's another dynamic. And of course, we've for a long time in Wales, we've had Healthy Working Wales, which does have a website, again, which provides a one-stop location for people to have access to the support that they can get during coronavirus and hopefully beyond as well. There's lots of guidance, toolkits and videos available through that. So there's a whole range of these resources that can be used. And I think part of the challenge is to make sure they're advertised, widely known, that people have access to them and can easily access them. I've been talking with Leonard Morgan, the Minister for Health and Wellbeing, and also for Welsh language, and she's been, I have to say, is passionate about this agenda, is regularly challenging me and colleagues in Welsh Government as to what more we can do to support mental health, to support that the one-to-one counselling, but also the wraparound support that we need to help people to remain and stay healthy and to rebuild mental health when that's needed. So, what a difficult year it's been. It continues to be. There are some positives in there. Different ways of working are abounding now. I think that brings some benefits potentially. Daily strain of commuting through traffic has not vanished entirely, but it's certainly less than it used to be. Remote working enables that, but remote working also brings challenges. People can feel isolated. We've certainly seen that in some of the teams that I work with in Welsh Government. So, I think we're at a really interesting time in the coronavirus pandemic now. We have a bit of light at the end of the tunnel. We've got an extraordinarily difficult winter to get through. I think January is going to be really difficult for NHS. It's great that we have HHP there as one of the support mechanisms. I would hope that, when we kind of look back on this year, with the benefit perhaps of getting through next year, when we look back, we will look back not just as a time when we were fearful and where we were challenged and stressed and found life terribly difficult. I hope we will look back with some pride to know that we did everything we could. We looked after the people of Wales. That's what we're all about, as health and care workers. We looked after the people of Wales. We did the best for them. We tried to reduce death. We tried to reduce the harm. But we also looked after our most vulnerable populations within that, because we know that the pandemic isn't evenly distributed, the effects of it. So I hope we will be able to say that, and I hope we'll be able to look back with pride and say that we recognise the sacrifices that our workforce made in health and social care, and that we looked after each other and we looked after all of our frontline workers. So that's all I wanted to say, John. But just to thank you for the work that you've done with the HHP, and thank everybody for their interest. It is one of the strengths, I think, of our system in Wales, that we are small enough to care for each other and to look after each other. That support is so important. Thanks very much, John. Really appreciate it.
Thank you very much, Frank. That's really, really helpful and gives us a great overview of the situation. Really grateful to you for coming along and joining us today. You're clearly very welcome to stay for the whole of the seminar, but obviously we appreciate that you may have to go off to other commitments. So next up on the programme is a joint piece really between Debbie Cohen and Jake Hard. So Debbie, as we've mentioned already, set up HHP Wales back in 2012 and has led its development really over the years, including securing the funding for it to expand as a result of the COVID-19 crisis. Deb is an emeritus professor at Cardiff University and has a background in occupational health. Jake is co-deputy director of HHP Wales and has a background in general practice. Jake has undertaken and does undertake a range of different roles and is another person who is full of wisdom and sage advice and has really helped with the development of HHP Wales. He's a key member of the executive team and he oversees the doctor advisors who really are absolutely essential to the delivery of HHP Wales. You'll be hearing more about theirs and other staff's roles as we go on. Between them, Debbie and Jake are going to cover the history, vision, service provision and current activity within HHP Wales. So without further ado, I'm going to hand over to Debbie. Debbie now lives out in the country, and so the internet signal does not always behave. And so Debbie asked me to advise you that she'll start off with video, but may switch that off if the signal becomes a bit iffy. So Debbie, over to you. Thank you very much for talking to us.
Okay, thank you. And I'm just so delighted to be here, even if it is from my distant farm, and also just to see how everything has progressed, because it's been a long journey really over the years, and that's what I'm going to do, is just kind of give you a taste of really where this all started. In fact, almost 20 years ago, I can't believe it, it's about 20 years now. But I want to start with a quote that is very dear to my heart, from a junior doctor, and I just want to read it to you. So 5 years since qualification, I've learned that if I truly felt the sadness and enormity of the things that have passed through my hands, I would drown. It needs to be okay to talk about that. Now, to me, that's really important, you see, because I think we take for granted about how far we've come in terms of the services and the support we have. Because when I started at this in 2000, it didn't exist. There was nothing, absolutely nothing. And really, I want to give you that sense of history to understand really how far we've come. And so in 2000, not only did I start being interested in this field and set up a small service for doctors in distress, and mainly trainees at that time, but there was a very tragic case of a psychiatrist called Daksha Emerson, who took her own life and her baby daughter's life in a most tragic way. And it really hit our community in terms of what had happened and where maybe we as doctors had let down our fellow doctors. And out of that came a report. So then, but it took till 2003 for that to happen. And in that report, it basically said, we need to do more. What we have done is not enough. We do not have support effectively for doctors. And it was particularly talking about doctors at that time, because Daksha Emerson was a consultant psychiatrist. And that we needed to be more effective and more efficient and more supportive. But it then actually took till about 2008 for us as a group to come up with what must be those principles of care. So if we're going to care for doctors, if we're going to make that happen, we need to have a robust way of doing it. And what were those principles of care that we as a group needed to agree on? And I tell you, at the heart of that was a confidential, independent service run by senior professionals who were easy to access. And I don't think it's changed, but that's where we started, because we didn't even have that at the time. And out of that, then following over the next 2 years, there came a review that I again was part of, which came to a publication called Invisible Patients that some of you may have heard of, and some of you might have even read some of it or bits of it. But really it was about trying to bring together all the research that there was there and the experts in the field to say, if we want to bring equity to doctors in terms of them receiving support, what might that look like? What do we need? If we're going to have a service for these doctors, what do we as experts think that service should be? Because it still hadn't really happened at that time. And that was meant to be UK-wide. And really, that's when I started saying, we're going to have to do something for Wales. This is not just about England. We need to think about Wales as well. And we all agreed at that time that we would call this work, which we now talk about physician health, but in that time, we really talked about health for health professionals. Now, we very specifically called it health for health professionals, because we knew we wanted to start with doctors, because the main reason for that was the equity of care, because it was clearly obvious from the research that other health professionals could access help in a more effective way than doctors could at that time, okay? And we had research about doctors, but we didn't have research about anybody else. But the agreement was amongst us all that eventually this should be rolled out to all health professionals, but not just doctors. And in 2012, as Jon said, and as Frank mentioned, I persuaded Welsh Government that we had to have our own service, that Wales needed one for Wales, and that it might be different to England, but let's start with something that we could lead on. And Wales committed to it. You know, they said, yep, let's do it. And we had repeated funding since then to run the service, which was in its entirety until the pandemic, and we'll talk about how it's developed since then. But this was not about doctors being different, being special. It was about equity. Doctors needed to be able to access some confidential support, which they really couldn't do at that time. And we needed to get to those people who were vulnerable, those who were stressed, those who were distressed. And so it had to be a very carefully thought out service. And actually, what I'm amazed. I sit here and realise that actually the people that you're hearing from today, so Naomi, Marfel, Jake, Bernhard, Sue, Ensaf, Rashid, do you know what? They've been with me since 2012. They've all been highly committed to this. And they've stood by me in all my pushing about, let's do more, let's do it differently. So they are an incredibly committed group of people. But we always saw it as just the beginning. There was just going to be, you know, it was only doctors now, but we needed more. And I also then started saying, well, this is great, but it's not good enough, because we want people to come before they're so distressed. We want to access, you get them to access help before they get to the point that they are drowning, that they are feeling so distressed. So I eventually persuaded, because it was not what you might call a sexy topic at the time. You know, there was no research money for this. But actually the Wales Deanery gave me some money to start doing research into the area of disclosure of mental ill health in doctors and medical students, because it was really not done by them. There were a few papers out, but really nothing much. And what that led to was a 4-year programme of research around the disclosure of mental illness in doctors and medical students that helped inform how we developed the service. And I just want to point out just one or two of the key findings from that research, because it is so important that we don't make assumptions, that we know what the issues are. And you know, there was lots of stuff about what inhibited, what stopped people getting access. I wanted to know what made them go to help, what would enable them to seek help. And do you know what? What we found, which was very interesting, is what doctors said they might do if they became ill was not what they did when they became ill. So doctors said, well, you know, if I was quite ill, I know I'd go and access help. I know I'd do it. But when you talk to the doctors who had been unwell, who had mental illness, it took an awful lot for them to go and get help. An awful lot. And they waited till they were in extremis before they got help. And that actually hadn't been noted before. Nobody had recorded that. And also, even, you know, in the last 2 or 3 years, doctors still weren't sure about how they could access help. So as Frank's saying, we've got to make sure that we are able to allow people to find out how to access help more effectively, because it's still not good enough. We cannot sit on our laurels and say we've sussed it, because we haven't, definitely haven't. And also, how old you are, the younger you are, and hospital specialties were more at risk than those in general practice and older people. So they were more at risk of having some severe episodes because they would not disclose. And again, something that had never been documented before. And the one thing that I think that came out of this most of all, which was most important to me, was that the first time people disclose, if they disclosed and the person they were disclosing to got it wrong, i.e. it was a bad interaction, those people, those doctors with mental health would not disclose again. Many of them never disclosed again because they had such a bad experience. But those who did have a good experience went on to disclose more. So they disclosed to more and more people and it became easier and they became more supported. So if we don't get it right at the beginning, we're having a problem. And again, that hadn't been noted. And acts of kindness. Acts of kindness, what really helped. So just saying, you don't look great today. Do you want to have a cup of coffee? Can I talk to you? What can I do to help? Had a major impact on those people that were distressed. And that also impacted on policy, okay? Because it's all very well saying we support people, but our policy has got to support that too. And very often what they said was there was a lack of kindness in our policy. The way the wording was, the way the language was used, the way that policies were implemented were not kind to those people suffering. And there are many, many instances of that. And there's some in our papers if you want to go and read it, but quite shocking, quite shocking. Anyway, we did that and we built into our service and we went from strength to strength. And as we've discussed, and in fact, we were just talking about expanding our services to beyond healthcare when the pandemic hit. So we were already started that process, but then the pandemic came. And actually, I'd retired by then. I was sat in my farm by the time the pandemic came and lambing and looking after my granddaughter but still managing the service. And it was absolutely clear to me we had to act quickly in Wales. We had to do more. So, and we needed to think differently. We needed to think, how are we going to support people? How are we going to access all healthcare professionals? How are we going to offer that service? Because we have limited staff, so we needed to be clever about how we did that. And APSI, as Frank said, Welsh Government bought it. They said, yes, Debbie, that's fine. We'll do it. Tell us what you want to do. And that's when it became so important for me to be able to have such wonderful colleagues as Jake, as Jon Bisson, as Thomas Kitchen and Naomi to help build this and take it on. And I'm going to hand over to Jake now to talk about what you've done since the pandemic.
Thank you so much, Debbie. I hope you can all hear me. Wow, what a hard act to follow there. It's been, I have to say, an absolute inspiration to work alongside Debbie for the last 8 years, and actually to be part of the progress that we've been making in the last 8 months for HHP. But yeah, thank you for all of your wisdom and your insight for the last 8 years, because we wouldn't be able to do what I'm about to hopefully demonstrate to everybody without that. So I've titled my talk in theme with the presentations we've had so far, really about how we transformed those early interventions for doctors into a national approach for an NHS workforce. So I'm going to hopefully through this talk just give you a brief overview of the current service model, the challenges we faced in those changes, how we've broken that new ground, and what we've learned so far, because there's absolutely some lessons to be gained from this. As we've heard a little bit about the previous service, just some sort of broad outline figures. It was originally intended from the outset to provide 8 sessions or access of 8 sessions of CBT for doctors living and working in Wales. We were not and are not providing an emergency service. We're not providing a clinical service, and that remains the same. As Debbie alluded to, the point of contact is essentially our doctor advisors. By and large, these are and have been GPs or occupational health doctors who have that initial discussion I've called it a triage discussion here, but it's really important that it's understood that it is a listening ear, and that act of kindness of being able to have an empathetic view from the person as they speak to you about the issues that they face, and also to help ensure suitability of onward referrals to the therapists. So just to give you a snapshot, just remember a couple of numbers. In the first 8 years, we received over 600 calls, and that's an average of about 2 referrals per week for doctors into CBT. With COVID, as has been said, Welsh Government's requirement was to expand the service, and the initial aim was to support all frontline healthcare workers, and then it turned into or evolved into NHS workers, and has been alluded to, and I'll show you some figures later on what that means, but also to help provide a tiered approach. So in effect, what I'm saying is that we had to kind of expand in 3 different angles. We had to both expand what we were providing, who we were providing it to, and of course the team that was supporting it had to expand. So the service model itself had to expand, as has been touched on, and we are now providing a tiered approach, which includes providing self-help resources, a peer support network, guided self-help, and of course CBT sessions through our bank of therapists. And we're also doing some work to address post-traumatic stress disorder as well. So we've got a whole range of things that we're now offering, where previously we only offered the CBT. So what do we need to deliver this service? Well, of course, we needed a larger team, as I've mentioned. We needed additional development of the resources within those different tiers, and new ways, of course, of reaching our client group. So we needed administrative capacity to take the calls, deal with the referrals that come through our online form. As has been explained, in a way, the senior management team's gone from, just Debbie as it was previously, and Naomi, to Debbie, John, Thomas, and myself, as well as Naomi and a few other members of the team as well, to help expand the management process. The campaign to raise interest and cascade and broadcast the fact that the services is available has been challenging, to say the least, because the network is so varied and so diverse. And we continue to need and will need help to continue to build that network as we spread our tentacles into the various workforce domains. So the other aspects that we needed to enhance were the doctor advisors. So there were previously 4 doctor advisors. I think we're now up to 8, and we're looking at recruiting another 2 or 3, because these essentially, the doctor advisors are in a way that front door to our service, that first listening ear, that first point of contact that's so crucial. And I guess I'm biased as a GP. The vast majority of them are GPs. They've got those natural listening skills that hopefully you would expect of GPs to be able to provide, although we have got some doctors with other skills, and in line with emergency measures, we've been able to utilize some doctors that have come out of retirement with COVID-19. Thomas can speak much more about peer support. This is a whole new level of support that we didn't provide previously. I think we've got a significant number of people who've offered voluntarily to provide a peer support network, and we're slowly seeing that increase in its demand from the people that are contacting our service and the uptake of peer support. And of course, we needed therapists. We always struggle geographically with our therapists in meeting the needs of doctors around Wales because of the size of the nation. We have increased, I think, about 3-fold the number of therapists that we've got. But of course, we've had an advantage here with COVID in doing things remotely, that we can do, or the therapists can do a lot of this through the virtual platform. So alongside this, managing it, we manage through weekly team meetings, monthly team meetings with our advisory board, and taking on board additional expertise, all done virtually. And we continue to do so. We've developed an SOP on how it works, which is ever expanding. We continue to discuss with our partners and stakeholders how we can best meet the needs in other parts of the NHS. And of course, we're in the active process of recruiting the right people into the right roles, and we continue to do that. But I have to say, on that basis, I've been overwhelmed by the contributions or willingness of people to contribute their time, whether it be on a voluntary basis or a paid basis, to help with the charge that we have been given, which is to help and support our workforce. So alongside of this, we have required a whole load of training and professional development for our doctor advisors and peer support workers, which again, we've had to do all virtually and remotely, and we continue to do on a regular basis. So I'm just going to pause there just to remind you of those figures: 600 calls in 8 years, 2 referrals a week. Since the expansion in mid-April, we've had, up until this week, 339 people referred or signposted on in that 34 weeks, which is about 10 referrals per week. So, you know, 5-fold increase in the number of referrals we're taking. And about, just to give you some insight, there are about 103 of those have been, we're still referring about 3 referrals a week of just doctors. So even that has increased. We recognize that because of the word of mouth aspect of our service, we will probably see a significant proportion of people coming through our services will be doctors because they, you know, historically we've been looking after that aspect of the service for so long. So, and just to give you a little bit more insight, since mid-July, we've been picking up about 14 referrals per week. So that average I gave you above is across the whole piece. But since mid-July, it's increased even further. So about 14 referrals per week, of which 4 are doctor referrals. To give you some idea, I'm not sure these figures are quite up to date, but we have had a number of referrals in for self-help. So that is a very small number, but slowly expanding, and certainly has been expanding in the last couple of weeks. And again, we're sort of slowly seeing an increase into guided self-help, and certainly a significant increase relative to the initial progress with the peer support network. We've had about 16 referrals in there. And we continue to refer into other services like the BMA, obviously signposting people back to occupational health and GP services where we need to. This is a graph just to very briefly show you what it actually sort of physically looks like. You can see that there is a trajectory gently raising towards the right-hand side of the screen as we are going up, and you can see that we're taking fairly consistently over the last 5 or 6 weeks, on average about 20 calls per week. And that will continue to rise. You can also see that we're predominantly taking most of those calls via email, or rather most of those contacts via email, and some of them are still by telephone. People are still wanting to telephone and speak to somebody. This is a very heavy slide. It's got lots of figures on it, but I wanted to give a little bit of insight into the breadth of the people that we are helping. So just take a moment and read around the slide, and you can see everything from human resources to the doctors I mentioned, a significant number of contacts from the ambulance service. Even therapies have been contacting us, whether that be occupational therapy, speech and language, and physiotherapy. Radiography has obviously had a need to contact us. So a real wealth that we're seeing. And I have no doubt that the list that you're seeing now, which has expanded in the very few months I've been involved with this expansion, will continue to expand because we know that the NHS workforce is so diverse. So the pressure points for us, I guess, is this idea that we are dealing with the whole of the NHS workforce in Wales, and we continue to want to support everybody. But actually what we've discovered is that it is an increasingly diverse organism, the NHS, and it comprises a really huge number of different professional domains. What we've discovered is that word of mouth continues and remains to be a key sign of the service's positive impact, and a key method for new people, new clients coming to our service. And speaking back to Debbie's point, you know, if people have a good outcome from contacting our service, they are much more likely to tell their friend, their colleague, their family member, whoever it may be, that the service is one to approach. I'm conscious of time, and I've got a couple more slides which I'm going to skip just because of the timing, but we continue to do some work around evaluation. And I'm going to skip over those slides because they're a little bit too detailed. There is a quote here which I'd also like to read, or you can read for yourselves. So we continue to gather feedback from our clients as they come through the service, and of course we take that feedback on and continue to adapt and evolve our service. Key priorities for us going forwards: we are hopefully imminently going to release our improved and updated website. We will continue to campaign to reach out more widely to our NHS workers in Wales. The evaluation bit I haven't touched on in much detail, but we will be evaluating the outcomes, particularly from our CBT therapists. And one of the other ambitions I've got is to make sure that we, the service incorporates lived experience within our service. So my final slide here, and many of the reflections that were brought, if you like, from the outset from Debbie remain extant. So there is a strong ethos of caring for our carers within the whole team. One of the most important learning points is that the service that we had is absolutely suitable and relevant to all health workers. I cannot understate that enough. And of course, confidentiality and independence are key attributes. They remain absolutely the foundation of the service that we provide and continue to be one of the most attractive features for people contacting our service. And a reflection, I guess, from myself and the team, and despite the numbers I've shown you, I think we accept that we are really only touching the tip of the iceberg of need. And I think that's it from me, but you can contact the service through the helpline page, the website page, or that email address, and you're welcome to contact me personally for any questions on my Cardiff email address. Thank you very much.
Great, thank you very much, Jake. That was really clear. So, and thank you very much also to Debbie. I think, you know, the combination of Debbie and Jake there really, certainly I thought gave a really good insight into what HHP Wales is all about, where it's come from and where it's going to, really. We're now delighted to welcome Neil Greenberg to join us. And in fact, just before I introduce Neil properly, I should apologise for overseeing my role as being the person that gave out housekeeping points at the start of the session. So apologies for that. At least I don't have to talk about fire exits or anything like that today. But what I can talk about is the Q&A box on the screen. So if you have got any questions this afternoon, please do type them into the Q&A box, or as a couple of you have done, thank you, into the chat box, and we'll make sure that we keep a record of those, and then we'll try and deal with all of those later on when we have the questions at the end of the afternoon. So next on the list, as I said, is Neil Greenberg. Neil's Professor of Defence Mental Health at King's College London, a consultant occupational and forensic psychiatrist. I've known Neil for many years and certainly can vouch for his excellent work in the field, and he's been a real pioneer in several areas, really. I mean, something that he's very famous for is sort of increasing awareness of trauma risk management and getting that adopted within the defence services. And he's also played a major role in increasing recognition of moral injury more recently. Clearly, with his military background, it's a very important issue there. But also, it's one of the things that we've been considering. There's great potential for members of NHS staff to experience as a result of the COVID-19 pandemic. So Neil, we're really grateful to you for joining us, and can I pass over to you?
Absolutely. So I'll just try and find my slides here, which should be somewhere. It says show windows, show sound. No, it's not. That's too long. Apologies. 1 second. I've just got to find the right presentation. I'm gonna... I should have learned to whistle, shouldn't I? Then I'll do much better at keeping there.
No, that's great, Neil. While you're just looking for that, maybe we can just pick up one of the questions that has come through, which is what proportion of the increase in people using HHP Wales is better knowledge, and what is more health professionals are suffering from the ongoing pandemic? And I think the answer to that one is that we don't know yet what the answer to it is. We definitely saw an increase in number of people coming in when we opened it up to more groups of NHS staff, so that would be a sort of an increased awareness and sort of being able to take on different people. But we're definitely starting to see people coming through who we definitely feel are impacted by the pandemic itself. And probably, again, that's not a bad segue into Neil's talk. So Neil, you look as if you're up and running there.
Thanks very much, John. Yeah, absolutely. So thanks very much indeed for inviting me to speak. I think John's kind of introduced me pretty well. There's no need to go over. If any of you are interested in Twitter, that's my Twitter handle. I'm sure just like John's work, we try and pump out our research on Twitter as early as we can if we get a new paper out. So by all means, follow me if you're interested in that. So the aims of this talk is to talk about moral injury, talk about what we know, and most importantly, also what we don't know, say why it matters, and then kind of give an idea into things that we think can make a difference to improve the situation. So it's worth saying that moral injury's background really is the military. I'm going to try and hopefully show you a video for 4 minutes, which gives you a bit of an insight into the topic. And then I'm going to go through and talk about some specifics in terms of the research we've done with the military, but also some now which just emerging also with healthcare workers. And before we get onto the video, it's worth saying that what moral injury is, if you're not aware of it, is a situation that strongly clashes with your moral or ethical code. So, let's hope this all works.
Moral injury. What is it all about? What is moral injury? Moral injury refers to the intense psychological distress which can follow actions or the lack of them, which strongly clash with someone's moral or ethical code. Whilst moral injuries are not mental illnesses, they can cause strong feelings of shame, guilt, or anger. The history of moral injury. Moral injury is not new. It was first written about possibly as far back as the ancient Greeks. Since that time, there is continued evidence of its impact on military personnel up until the end of the Vietnam War in 1975, and of course in subsequent conflicts as well. Moral injury does not just affect the armed forces. Whilst the term moral injury is often linked to military service, it can affect many other occupational groups, including media professionals, social workers, healthcare staff, vets, lawyers, and aid workers, to name but a few. What causes a moral injury? Moral injuries may occur in 3 ways. Firstly, when an individual or someone else has done something which they should not have done. These are known as acts of commission. Secondly, when an individual or someone else should have done something but they did not. These are known as acts of omission. Thirdly, when an individual feels betrayed by others, often by a higher authority. The spectrum of psychological difficulties. Moral injuries occur along a spectrum. Some people don't seem to be affected much at all. Others experience short-term distress with no substantial lasting impact. However, when the if-onlys and what-ifs do not go away but become more intense, then a moral injury has developed, some of which develop into a formal mental health disorder. What is the impact of moral injury on mental health? Research carried out by King's College London shows that morally injured people are vulnerable to developing other mental health disorders, including PTSD and depression, and experiencing suicidal thoughts. What are the risk factors for moral injury? Certain situations make moral injuries more likely. Events involving vulnerable people, such as children or injured colleagues. People feeling unprepared for the emotional consequences of their role. A lack of social support, or people who experience traumatic and morally challenging situations at the same time. Moral injury acts as a barrier to recovery. Unfortunately, people with moral injuries often feel ashamed, guilty or angry, which can make them very reluctant to talk about their difficulties with anyone, including clinicians. They may worry what others will think of them or even get in trouble with the law. However, because they don't speak about their experiences, they can't make sense of them, and so they don't get better. Treatment for moral injury-related ill health. Currently, there's no clearly defined way to treat moral injuries. Clinicians therefore find it difficult to provide support to those who experience them. Some psychotherapies may also make moral injuries worse. Currently, the most effective way to provide support or treatment for moral injuries is to help people make sense of what has happened to them. Conclusions. To sum up, moral injury is not new. It's often linked to the military, but affects people from all walks of life. It's not an illness, but it can have a serious impact on people's lives and lead to a range of mental health disorders. If someone has a moral injury, they should be helped to make sense of their experience or be encouraged to seek professional help.
Okay, so that's kind of the overview for kind of what moral injury is. If you're interested in that video, it's freely available on a YouTube channel somewhere. So moral injury is often talked about in sort of the same breath as post-traumatic stress disorder. And it's fair to say that there are lots of reasons for that, and there are great similarities. But it's important to note that moral injury is not an illness. It's not a mental health disorder. You won't find it in the ICD or the DSM, whereas of course PTSD is a diagnosis. Important to note that with moral injury, that it particularly affects these deep moral beliefs and judgments and values that you have. PTSD, on the other hand, often is around situations where you feel threat of some sort. And so what's lost with PTSD is often safety, whereas with moral injury, what's often lost is that feeling of trust. And the emotions, again, there are overlaps, but PTSD has classically been fear, horror, and helplessness, whereas moral injury, the classic emotions there are guilt, shame, and anger. We did a review on occupational moral injury and mental health associations. And what we find is that the biggest association, unsurprisingly, is with PTSD, but there are also significant links, associations with depression and suicidality. But certainly worth saying that at this stage, most of the studies are conducted in the military. And of course, whilst we know moral injury affects other groups, we're not quite sure how well the military data will translate into other occupational groups. We ran a study at King's called the Imagine study, and this was looking at moral injury in ex-service personnel. We had both quantitative data collected through questionnaires and also qualitative data looking at veterans, but also care providers and also clinicians. I just want to give you some of the quotes just to give you a flavour for what moral injury is. And what you can see here is somebody who is talking about the fact is that in the military, you are asked sometimes to end people's lives. Now, that's done, or it should be done, in a way that is consistent with the Geneva Convention, with the law of armed conflict. But here, this person is talking about the fact that however legal and appropriate it is within a theatre of war, he is seeing what he has done as murder. And of course, if you want to get into the legal definition, what he has done is not murder, because murder is unlawful killing. Whereas killing in war is lawful. But yet, from his point of view, and these were all men, I would say, there is a real difference, and there's a conflict between his set of what he sees as values and what's actually happened. When we were looking at this, we strongly felt that actually moral injury was likely to once it was there to kind of to sort of stay with you, and it may have trouble in resolving. And this quote, I think, was really quite an eye-opener for us. Because this particular individual kind of seems to have made a decision that actually they're suffering with these strong moral injury related emotions, but they kind of had enough of it. They don't want to go down a pathway that they've seen on the news and in the media and maybe in their colleagues of having a terrible life and maybe suicide. And so what they do is they decide to, that's it. I'm going to stop thinking about it. I'm going to put it in a box effectively, and I'm going to move on. So I think that what this says is actually that reflecting on it, thinking about it, sometimes can help, but you get to a point that either, I suppose, it has the potential to make you ill, or it has the potential to say, right, well, I've done all my thinking and I'm moving on. Another thing that's often not linked directly to moral injury in literature, but actually we find is quite common, is this concept of post-traumatic growth. That actually many people do go through these morally highly ambiguous situations, and actually at the end of it, they come out psychologically stronger. And we're just doing a study now in healthcare workers where we are using the short version of the post-traumatic growth inventory to try and look for the links between moral injury, mental health, and post-traumatic growth. And we think very strongly that a lot of people who in our sample, it's about 20,000 strong, will end up actually not necessarily becoming ill, but actually going on to experience some post-traumatic growth. There's also a bit in the literature about the impact of spirituality. And for some people, spirituality is something which can be quite protective. And actually, when you get put in these morally ambiguous situations, it can often make your perception of what your spirituality, what your religion is about, even stronger. And there's a great phrase here, which is no such thing as an atheist in the trenches, but you have to believe in some greater meaning to the chaos that many war situations are. But on the other hand, some people have seen things that just strongly challenges even their religious beliefs, and they can't then get their head around the fact that if there was some greater being, that they could let these terrible things happen. And so that's what this quote is really there about. We know from our quantitative data, there's no doubt that even if you're not ill, moral injury by itself impacts upon family functioning. People don't want to speak to their family because they think their family will think they're a monster. If they turned away a child when they were on deployment because actually they had to do their operational tasks, what is their family going to say when they hear about dead children? And they think that it's their responsibility, it's their fault it happened. We know it also impacts upon occupational functioning. We measured that in our surveys, the work and social adjustment scale, and we know that actually there's a link there between just suffering a moral injury and functioning poorly. And as the video said, there are some real treatment challenges. One of the ways that is often used to treat PTSD is something called prolonged exposure. So it's going over the situation in a safe way to try and habituate to it so that it no longer becomes something that causes you intense distress. Well, there is some evidence from studies showing that actually for people whose traumatic situation is associated with moral injury, actually this doesn't seem to help and actually can make things worse. Going over and over and over it doesn't by itself lead to a resolution of symptoms. So the challenge is really, how do we find a way to challenge these beliefs sensitively without necessarily re-exposing people to the anger, shame and guilt that they're experiencing. And one of the things that we think is important with moral injury is we have looked at the impact of both moral injury and then what we might call classic trauma together. So if you've got someone who comes in and talks about this situation that was potentially threatening their life or was really horrible to see or to witness, they may end up in therapy speaking about the symptoms of horror, helplessness, and fear quite strongly. They may talk about them, and the therapist may get on and treat those symptoms and do a really good job. But because the morally injurious aspect of the incident, the fact that they think they did the wrong thing or they didn't intervene when they should have done, because that's associated with really strong feelings of shame and guilt, actually they don't talk about those symptoms. So the therapy ends with the fear and the threat having been dealt with, but actually the morally injurious aspects haven't been dealt with at all. And what we think this means for clinicians is that if you have a traumatic event and you're talking to someone about it, then really you need to probe gently but sensitively about the potentially guilt, shame and anger aspects to those situations, and not just expect people to talk about them, because quite often those feelings are associated with this real sense that they can't talk about them honestly, because if they do, then people won't think that they're a reasonable human being. And this also links on then to the next important thing, which is about military, but is just as important with professional registration and with healthcare professionals who are, have governing bodies, is what do you do when you have a mental health problem and you speak to a clinician hoping to get some help, but actually the reason that you have the mental health problem is that you've done something wrong. You know that actually you gave the wrong drug to someone and a patient died, and that's why you are so distressed. If you're in the military, then you know that you got angry and you shot someone when you shouldn't have done that. So that is going to lead to a war crimes investigation. So the question is, how does a person start getting help for something when actually the consequence of getting help is going to be pretty terrible for either their career or maybe even from a legal point of view. And we wrote a paper looking at the difficulties that clinicians may face in trying to help patients who might have moral injuries, particularly ones who are worried about the legal or occupational impacts of disclosing them. How do they encourage people to talk to them about them? Because if they don't talk about them, then they may never get better. And what we strongly suggest is that actually you reassure people up front that you don't need to get into graphic details. You don't need to know specifically what happened. And if people start to say, listen, doc, can I tell you about this? You should remind them that there may be situations in which you would have to divulge that information to somebody else. And if you end up in a situation where you've heard information that worries you, we strongly advocate, unless there's immediate risk, that you should discuss that with a senior colleague. And I think one of the reasons that this is really important is we know from the PTSD diagnostic criteria that distorted perceptions can happen quite often in PTSD. And so when someone says, I did this terrible thing, and I really shouldn't have done, the question is, are they really saying to you they did it, or are they saying to you that they perceive having done it and they think that they were wrong and they think that they did the wrong thing? And what we're suggesting is you should not just leap into phoning up the GMC or phoning up the SO15 war crimes helpline and reporting people without some strong consideration of the potential that someone may not be telling you a fact, they may be telling you a perception. And these things need to be thought through quite carefully. And actually clinicians who are potentially hearing these stories need some good supervision and support, and they need to know where to go if they have a dilemma about such a situation. And our research with clinicians suggests that actually people certainly working in the field of veterans mental health, some of them do worry about this, and they've had some psychological difficulties themselves as a result of having to deal with these really challenging cases. Another difficulty with moral injuries, we don't really have a good screening tool at the moment. There are tools out there that look at the event. There are also tools out there that look at the potential impact of a morally injurious event, but they don't seem to fit into the same tool. So we're just working on a scale, we call it the Morris, which at the moment is too long, but to try and encompass the whole spectrum of what a moral injury is and also what the impact is and your vulnerability. Because we think that once we can try and identify it better, particularly during therapy for PTSD, then we can better able to help people. And I think one of the interesting data facts about veterans and PTSD is we know that they don't tend to profit from treatment from PTSD therapies as well as non-veterans. And we think one of the reasons for that may well be the fact that they have significant moral injuries. At the moment, we've got a study which is just getting underway, funded by the Forces in Mind Trust, looking at trying to develop an outline treatment schedule for moral injury-based mental health problems. We know that when we've asked clinicians, clinicians do a whole variety of things to try and treat and manage moral injury, but they don't really have a clear protocol for how they deal with these particular bits. People use schema-focused therapies and they use cognitive techniques, but there really isn't a guidebook to try and help clinicians know what to do. So we want to try and develop one and then obviously do a trial to see whether that makes a difference. Now, just moving on to kind of, contemporary times, we know, and we wrote about this at the beginning of the pandemic, that moral injury is not just something that's restricted to the military. And we wrote a paper in the BMJ, which I don't think I've got here, which in March, which tried to translate situations that would happen regularly, unfortunately, to military personnel and how they might translate to people in healthcare. So during the early part of the pandemic, I ran the mental health strategy at the London Nightingale Hospital when it was open for the sort of 2 months that it was. And we put a lot of work into trying to look at the concept of moral injury and preparing people well. And I would regularly go down to the shop floor and speak to the staff as they were coming off shift. And many of them were struggling with the fact that they were a pediatric audiologist, for instance, and they'd gone to help out, they volunteered, and there they were doing this work in a really difficult environment. And they didn't know whether they were doing the right thing. They were really quite worried. And this concept of potential moral injury was definitely out there for healthcare staff. In our study we've got at the moment, which is called NHS Check, which covers 18 English NHS trusts including mental health and sort of physical care. We use a scale in that study called the MIES, M-I-E-S, the Moral Injury Event Scale. And what we're able to do is to split that scale into low, medium and high exposure to moral injury. And what you can see here is we've measured different forms of psychological measurement. We've got common mental health disorders, anxiety, depression, and PTSD symptoms. And you can see there isn't very much impact of moral injury or morally injurious events at the lower level, but there is a very significant increase in psychological ill health, probable psychological ill health, because obviously it's measured on questionnaires in those who have high exposure to moral injury, particularly with regard to PTSD, which is probably feeding into this anxiety here. So what we're saying here, what this is seeming to suggest is whilst moral injury is a potential difficulty for lots of healthcare workers, it's the people with the highest exposure who seem to be most affected by them. So what can you do about it? Well, we think the two things that you can do to make a difference is, first of all, making sure supervisors can talk to people about their mental health at work. And the second thing is about reflective practice sessions. And I'll just briefly cover these two things. We know that for supervisors, it's really important that they're confident to speak about mental health with staff. Lots of good evidence, a lot of it from Australia, I have to say, showing that actually if you can increase a supervisor's confidence to get beyond how you're doing, I'm fine, because we know that fine doesn't always mean fine, then actually you can potentially have a discussion which may defuse a morally injurious situation, because you may be able to reassure someone before they become completely distressed that they haven't done anything wrong or that the right thing happened. So with NHS England, we developed this, this process called REACT, which is a short active listening skills package. This is a 1-hour training course that we deliver online through Zoom, a bit of didactic teaching, a bit of a demonstration, and then we get people practicing how to do these short active listening conversations about mental health. We were looking to see whether we could improve supervisors' confidence. We've done 1,200 of these training, or 1,200 people have been trained. This is the very brief outline data. So before the training course, just over half of the people who attended were not confident supporters. And 1 month later at follow-up, about 85% said they felt confident to support colleagues who might be distressed and talk about mental health. So this is a very bite-sized piece of training. And what we're showing here is actually you can make a big difference to supervisors' confidence. And then reflective practice is basically the opportunity to sit round, you may well have heard of Schwartz rounds, and talk about the impact of what's happened to staff over a period of time or after a particular incident. And what you're trying to do there is to make a safe, a psychologically safe environment where people can say, do you know what, I didn't do the right thing, and everyone's not going to go, why not? They're going to go, well, I didn't do the right thing too. Because what you're trying to do is to create what we call a meaningful narrative. That is a story that doesn't end up with you being the perpetrator or you being the victim. It ends up with you, hopefully, led by the leader, being in a situation where you say, this was really difficult, but you know what, we tried our best and actually we did some good. And that's a much more psychologically safe place to be than I won't talk about it, it's all his fault or it's all my fault. Now, we don't know yet that these reflective practice sessions will make a positive difference, but the evidence we have from Schwartz rounds is that it shouldn't do some positive, have positive impact. So there's lots of unknowns still left with moral injury, which I've kind of covered on, particularly I think these legal ones as well that need dealing with. And my conclusion really is that moral injury is not new. It doesn't only affect military people. It's not a mental illness, but it does make mental health problems more likely. It can affect behavior. It can impact upon quality of care. It can lead to accidents. It can be diffused by discussion, and that can be with supervisors or with a team, trying to create this meaningful narrative. And that if you're trying to treat a mental health disorder that has a morally injurious element to it, you need to ask about it, and we need to work on those treatments properly to make sure we're not harming people. And we also need a proper measurement tool. So that's me. I've got, if I can, sort of a few minutes if any questions come up.
Brilliant. Thanks ever so much, Neil. That was fascinating. I really like your acronyms. They're great as well. Any questions for Neil on that? Looking at, so what you can do is you can type your questions into either the Q&A section or into the chat section, but unfortunately we can't hear you today because this is set up as a webinar. I mean, Neil, what in your practice and your experience, I mean, are you seeing a lot of people, coming forward for treatment, as it were, where you feel that moral injury is the underlying issue, amongst NHS staff, for example?
I think the answer is at the moment that there is definitely a very strong element of the conversations that are happening through NHS England has a central hub of resources. I'm sure the same goes in Wales. And so those are anonymous conversations. You don't have to say who you are. And what's coming through in those conversations is lots of people who are worried about, did I do the right thing? Did I see things I shouldn't have done? They're not necessarily coming forward for treatment. And if they are, we don't have the data to say that they're coming through yet. But certainly these are things on healthcare workers' minds, and they are talking about them when they can do so anonymously. Of course, what we don't know is whether the shame and the guilt and the anger will stop them coming forward to help. Time will tell, I think.
Yeah, and what do you think the role is then of sort of like the senior management within the health system? I mean, have they got a role to play in this?
Absolutely. So I go back to this kind of meaningful narrative piece, because so like early on, across the whole of the UK, probably across the world, the whole PPE issue was a big one. Why aren't I getting the right equipment? Why are you asking me to do these things? So I can only assume that the managers weren't sitting back, playing golf and enjoying themselves. They were probably trying their best too, but the situation was one that was impossible. And so what I really hope, and the whole idea of these reflective practice sessions, is that management at all levels feels that they can say, do you know what, I didn't get it right. And actually what we're trying to do is to come together for this belief that actually we all tried our best, even if the situation didn't make many outcomes possible. So I definitely think there is a role in management not being defensive and saying, well, you had everything you want, because that then leads people to down a pathway where they're not in a good place.
No, sure. And I see that Catherine Evans, who's one of the HHP therapists, has asked a question, which is, has compassion-focused therapy been considered as a modality when working with moral injury?
Absolutely. So we, as this study, I said, that's just taking off, trying to develop a treatment protocol. We're going to be asking people who have got backgrounds in compassion-focused therapy, acceptance and commitment therapy, certainly schema-based therapy. We think that actually we can draw bits from lots of those approaches to try and look at moral injury. But and so I think clinicians at the moment, when we spoke to them, are using compassion-focused approaches for something that they do. The question is, of course, what is the optimal sort of a way of doing that? But I'm confident that compassion will be in there.
Yeah, that's really helpful, Neil. Well, I mean, I know that we're at time, so thank you very much, Neil, and hope you have a good rest of the day, the year actually, and and see you soon. So for everybody else, we're going to take a brief break now for 5 minutes, and we'll see you back here again at 2:20, if that's all right. So in 5 minutes. So see you shortly.
Welcome back, everyone. I hope you've just had time to stretch your legs or check those things that need to be checked. We're going to move on to the next part of our session this afternoon, which is learning, I suppose, from some of the lived experiences from two of our colleagues, two people who are working in the NHS. And I'd like to just start from the outset by expressing our thanks to both Sarah and Natalie for being willing and volunteering to share their thoughts and their reflections around living and managing mental illness from their perspectives. So first of all, I'd like to I suppose note that I'm going to show two videos that we've recorded over the last few weeks, and I'll start with by introducing Sarah's video. Sarah introduces herself on it, so I won't say very much else, but thank you to Sarah for, as I said, sharing your experiences and your reflections, and look forward to what we can learn and think about as we listen to your story. Hi, Sarah. First of all, I wanted to say thank you for joining me this afternoon. Perhaps it would be helpful if we just started by introducing ourselves, and I wondered if you'd like to take the lead and go first.
Yep, so I'm Sarah. I've been a consultant anaesthetist in Cardiff for 22 years now, you know, I think you're going to find a little bit more out of me today. Is there anything specific you wanted to know other than that? That's my role in work, and I'm a mother of two kids, two teenage girls, and married to my husband, Lynn.
Thanks, Sarah. First of all, again, just continuing that, Sarah, thank you for joining us and being happy to share some of your experiences and reflections about your mental health with us this afternoon. And I wondered if you might perhaps start by outlining some of that story that you've already alluded to with us.
Yeah, of course. I guess things started in January 2018, so 3 years ago, nearly now. I was living just a normal, busy life. Never suffered with any mental health problems before, and life was good. I had a 14-year-old and a 16-year-old daughter, and was happily married. And then things started to unravel. And my mother died in the January. I coped with that relatively well. I think, you know, as people do, it was unexpected, but I got through it, but perhaps was a little bit reserved at home, taking my eye off the ball perhaps on my teenage girls. And unfortunately, my youngest daughter was diagnosed with anorexia in June 2018. This came after a period of depression that had been quite well hidden from the family. So we tackled it. I got on board with it. I thought I understood eating disorders. I was determined that we were going to fight to get my daughter back into good health. But unfortunately, it really took its toll on all of us. But I think I'm here to talk about myself and my role, how I coped at work and how I coped at home. And initially, I struggled on at a very high stress level in both areas. But by the August, my daughter was really severely unwell with needing 24-hour care with suicidal ideation and severe anorexia. And I found I just couldn't work any longer. I went to see my GP at this point and asked for some antidepressants, really because I knew I needed resilience to carry on what was going to be a long haul. And I was struggling to sleep, to eat, to focus. I gave everything to my daughter. Our lives were just turned upside down. So that was the start of the journey.
You've already alluded, Sarah, there to a few things that I suppose in hindsight you can reflect on, but what was it that made you perhaps first realise that things weren't right for you?
I think I thought I was just about coping at home, albeit that I don't think until you've lived through or known someone closely with anorexia, you really know what it does in a family, but it's incredibly difficult. But what I noticed was at work, my mind was totally on whether my daughter was safe at all times. And I was doing complex things at work and I just felt it was getting to be unsafe. And it was at a position where I thought I could be dangerous. So I thought I got to stop now and take some time. Initially, I just thought it would be a couple of weeks. I really did. I thought I'd just take some time out, talk to my GP. But the struggle that evolved, my daughter took an overdose a month later, and luckily she survived that. But really the care that was required, and I was unable to concentrate on anything else. So I continued seeing my GP monthly at that point. And the GP sessions, she was supportive, but it turned into just a horror story of life at home and not much about myself and how I was dealing with things. I was just having to do what was required. But so I wasn't really concentrating on my mental health. It was more everything was given to my daughter, which I don't think I saw any other way of doing it. And it certainly there was no other things offered at that point. So I carried on increasing the doses of antidepressants. So that was the first sort of 6 months, and I was off work for that time.
Yeah. And I suppose, what was it that made you first, what was it that took your seeking for help past that with the GP? What was it? Was there any points in that you made a decision or were given advice or experience from someone else?
No, I think I felt there was no time for anything else for me. There was no other space in my life to look at me other than that I went to the GP once a month. And that was all I could do. It just didn't seem right at the time to do anything else. And And I did ask to see occupational health at that point, because I was hoping to get back to work. And we got to a slightly more stable position with my daughter in the January, and I thought I got to go back to work. It was sort of one of those things I thought, I've taken plenty of time off now, I just need to get back at it. And I did a fairly fast return to work, to be honest. I think those of you that know about anaesthetists, there's no way of planning an easy work day. You can have an easy day or you can have a difficult day, and it's totally unpredictable. And after 2 weeks, I was just back in and working the best I could, and I just struggled on. I wasn't great, but I struggled through it, thinking this is where I should be. I've never taken time off work before. I should be working, and just coped at home just about. So we grumbled on until my daughter's second overdose, and then the world just stopped. The wheels just came off again, and I couldn't cope with anything. And that was a turning point for me, though, and a bit of a turning point for my daughter, because she really hit rock bottom there. So at that point, my daughter was actually kept as an inpatient then for a couple of months, and I turned to use that time to sort myself out as well, or to try and help myself. So I started. It was a colleague who told me about HHP, and I phoned them and had an instant response, very efficient, was assigned a counsellor who I managed to see within a couple of weeks. So that's how I started on my route with HHP.
Yeah, thanks, Sarah. We're about to just come back to the HHP sort of service in a minute, but just, I suppose, if there was any advice or reflections you could offer to other health staff at the moment, who appreciate everybody's situations are different, but if they felt that they were struggling or had hit those situations where you got to, was there anything that now looking back you could say that was helpful, and I wish I'd done that, or any of those kind of reflections you could offer to us at the moment?
I actually found occupational health very helpful when I did get to see them, and I actually didn't really understand what occupational health were there for, when they're very much there to support you. They're not there to. I thought they were working for the trust in a role to control workforce issues and things, but it's really not that. And I found them very supportive and very understanding of what was going on for me. And so seeing them earlier would have helped, just on my journey through. So I used them from that, sort of 8 months in, I started to use them.
Yeah.
It's difficult with the GPs. I've got I completely know their life is just so busy, but really the time spent 15 minutes with the GP once a month was just really just a tick boxing exercise, and wasn't helping.
Yeah.
So I guess once you get to the point of not returning to work, if you don't feel you're ready, you've got to seek extra help a bit quicker. And I wouldn't delay like I did.
And occupational health really in that particular instance were helpful and a positive experience. So that's really good to hear. Really, really exceptionally good. I saw 2 different doctors at varying stages, but they were outstanding, really, for me. I hope that that's what the service everybody gets. And coming back then, so a self-referral into HHP Wales at the time, which I guess is, was a few years ago now. So what was the experience with HHP Wales at that time, Sarah, for you?
As I said, a very efficient service. They took a brief history and talked about confidentiality and explained I think is it 8 sessions or 10 sessions? I can't remember exactly. 8, I think, yeah. And, it was well explained. I think I'm just going to be totally honest with this story now, because this is how it was for me. And I think that might help, that there's good bits and bad bits to this. I saw a very nice counsellor. We talked through, what was going on for me. But again, it did turn into me discussing all of my daughter's problems. And I found it was just it was a place for me to talk. I actually asked, can we do something to try and make my thoughts, to control my anxiety, perhaps an issue, so I was having problems sleeping. And we did explore them a bit, but it didn't make a lot of difference for me. Now, that could have been in the place I was in. Yeah. I completely understand that people, things help at different parts of a journey. I thought at the time that was it, that it just wasn't working for me, but I'd done my best. I just left it that it didn't really help much more than just a talking place. Yeah,
we've reflected, I suppose, before we started on this conversation about how we hope that the system that HHP Wales has created since then has got a bit better at managing the other end of that CBT. So wanting to focus or keep the focus on your story here. What happened then after that initial session or those initial sessions of CBT had finished?
So then I was actually referred to a psychiatrist. That was actually through I have an income protection insurance, and they had refused my claim. So they referred me to a psychiatrist who was going to assess me. And it was at that point that I guess I really saw how bad things were for me. I was probably at my lowest point. So this was, at least a year on from my first time going to the GP. Yeah. And the psychiatrist did a quite very medical assessment, I would say. It was all about symptoms and medication, but completely got it quite quickly. And again, it was a very positive meeting. At which point things did change for me, because my income protection wanted to get me back to work. So they offered me further sessions. And at that point, I would have taken anything. So they offered me some sessions with a local psychologist. And that was the turning point for me, increasing dose of antidepressants. And I started to have sessions with a psychologist who I met in January. So it was a bit of a delay getting on board, but it was at a point where really I was just really, really struggling to get through the day at all, so there was not a lot of, the symptoms had just got worse of depression, and our lives were just continuing to deteriorate at home, and the stress in the family was really tough on everybody. And I was fully supporting my daughter again off work. And we're now a year and a half in, so of constant care for a dependent, plus the problems I was experiencing myself.
Yeah, and how was your experience with that psychologist at that time? What do you think was different?
It was a different approach, I think, and I was asked to explain a lot more about myself and my life, and she made me understand the reasons I thought certain ways was because of my life previously, through upbringing and all my experiences through my career as well. And it made a lot more sense to me. And the techniques and the way we discussed how I was reacting to things really resonated with me. And I was able, even though I was pretty unwell at the time, to go away and really reflect on it, rather than the previous counselling sessions I just left. And I didn't really try and do anything in between. But this time I found myself stopping and thinking and working a different way. I really connected with the therapist. It was very, very positive for me. And we continued to work, and I had my last session with her in September this year. So I was with her for, I think I had a total of 12 sessions. Now, it was through my income protection, but she does work for HHP.
Yeah. No.
So
I think I can hear in the conversation that we're having now how, I'm not suggesting this, is certain, but how the conversation has shifted away from starting the conversation and the story around your daughter to a conversation that is very much around you and how you at that time weren't coping and have come to learn some new things about how we might cope a bit better.
Yes, yeah. And, you know, within a few months, and even though things were getting a little bit more stable with my daughter, it's still a very unstable area of our lives. But I was ready to return to work. And it was a different return to work. Well, for a start, it was in the middle of COVID. We're just at the start of COVID in April. And one of the things I found really interesting about returning at a time of real crisis for everybody was how much better I coped with things than other colleagues who were just coping with the onset of stress through dealing with COVID patients regularly. I was much better at coping with things at work than I thought would ever be possible. My return to work was really positive. And within a couple of months, I felt more myself than I had done in 3 years. And I honestly believe that's because I had learned to deal with things a different way. And I was reducing medication. Everything was looking more positive for me.
I suppose, so we come pretty much to now then, really, in terms of a time frame. And again, we touched on this just as we started our conversation this afternoon, but how are things at the moment?
Again, my happiness is very much dictated to by my daughter. And we did have a good 6 months and some steady progress. And as the roller coaster of mental health disease or illness affects people, we are having quite a big dip again now. And just the last couple of days, to be honest, have been tough for me. But I'm able to look at things more clearly. I'm not anywhere near where I was before, but I'm very keen to look after myself, not to go back there, and you know, determined to stay in work, because I can see that the part of me when I was out of work, I just disappeared. And work is a part of my life that I do enjoy. I didn't go back full time. That's the other thing to say. I've reduced my workload, so it is more manageable. And I am able to, you know, I think I have good support in the workplace, that if I run into any problems with myself or my daughter, I am supported enough to be able to ask for time off. I haven't needed to do yet, but I know it's there, and that helps me feel, you know, well supported. And occupational health were very good with that as well on the return to work. But yeah, so the bad days of the last few days, to be honest, I just know what I need to do for myself this time, and I'm able to separate myself from my daughter more.
Just you've touched on work bringing you happiness and a sense of being who you are. But are there any other things that you're doing now, perhaps, that you think help you to stay well or to stay better?
Well, interestingly, I would have always said that exercise was a place for me that I needed it. I would say that's less and less now. As long as I get outside, I've got 2 dogs, so as long as I can get out into the open air and feel nature, I find that very helpful. Sleep is important. When I get overtired, everything is worse, and sleeping is hard still at times. But those are the 2 things that I concentrate on. And although it's a difficult time, I use my friends. I lost touch with a lot of my friends. A lot of people don't know what to say, and it's very hard for them. I understand that. But people I didn't see for a couple of years, I have got back in touch with, and we'll meet for a dog walk. And I forgive people. You know, my attitude to people and life is totally changed. I was quite a driven person, and I just think of everybody's struggles in a much kinder way than I ever did before. And you know, there's some good things that have come out of this horrible, horrible journey of ours. And I do think it's not all bad. Some of the way I live my life now is better.
Thank you very much. It's been a real privilege to talk to you and to share, not just today, but the preparation that we've done for it. And I'd like to say thank you from me, but also from everybody listening. So thank you very much.
Thank you.
So my thanks again to Sarah for sharing those reflections, and particularly around some of the difficulties around experiencing new and in many ways unexpected challenges in life. Also explaining for us, I think, the impact of timing and relationships on talking therapies and the therapies that we can see and use. And also the challenges of living with an ongoing challenge, and how that can affect us on a day-to-day basis. So thank you very much to Sarah for talking us through your story. The next story that I'd like to, well, I have the pleasure really of sharing with you is from Natalie. And Natalie is a GP-ST trainee here in Wales. And again, I won't say much else other than to allow her to tell her story to us this afternoon, and be very grateful to her willingness for doing so. Hi, Natalie. Thank you very much for joining us today and for being prepared to share some of your experiences and reflections around your mental health. I wonder if you might just introduce yourself to the group, and then we can have a listen to some of your story and your reflections.
Of course. So I'm Natalie. I'm a GP trainee currently in the Aberystwyth area. I'm originally from Guildford in Surrey, and I trained at UCL in London. I've always struggled with anxiety ever since I was a teenager, moving away to university, and sought kind of counselling and support at various points. It really came to a head for me when I was in my 5th year of medical school. I was burning the candle at both ends with work and extracurricular activities, and sort of didn't manage my stamina with the transition into clinical medicine, and essentially burnt out and sort of opted to take a year out at that point. Started again for my final year at UCL, really kind of enthusiastic again about medicine. I'd rediscovered my passion in the year out, and then graduated. I moved to Oxfordshire and did my F1 in Oxford, my F2 in Reading, where I generally sort of managed quite well. And then I moved to, I'd done my final year elective in the Aberystwyth area, really liked it. So I moved here to start GP training 18 months ago. I chose to start at 80% because less than full-time training, because I'd kind of recognised from my struggles with anxiety that full-time work wasn't ideal for me. So I started my training 80%, which was a really, really good move. And then at the start of this year, I was struggling. I felt my anxiety symptoms flaring. It was mostly issues in my personal life, and just sort of difficult various things I was trying to manage at home, as well as my wedding being cancelled because of COVID. And then sort of, yeah, being a junior doctor amidst a global pandemic, and I quickly felt overwhelmed. So I realised I was struggling and approached my GP. I was a little bit nervous about approaching my GP because up until that point, I'd been self-managing my anxiety since moving to Wales. And this was the first time I was seeking help now that I was in Wales. I was aware that it was a smaller community. And I was also aware that I was about to rotate into a 6-month placement in psychiatry locally. So I was a little bit nervous about reaching out, but my GP was great. Didn't make me feel judged for being a healthcare professional and struggling. So she told me about the HHP program, and I was really pleased because I hadn't known that existed. So that seemed like a really good option, and I got in contact with them and was set up with a lovely therapist who I met with 8 times, and it really helped, and I've been doing much better since. So I'm very grateful for my experience in the HHP program.
Thanks, Natalie. I just wonder whether we could reflect back on what it was that you felt you noticed about yourself, as it were, triggers or particular things that made you feel and aware that perhaps you needed to seek some help and some assistance.
Yeah, so for me, over kind of the last 10 years, I've learned to recognise the triggers. For me, it comes down to a lot of worrying. I find the unhelpful thinking styles concept really helpful. I often look back at the poster of that and think, yes, I'm doing that. Oh yeah, I'm doing that. So I start to notice the catastrophizing, those sorts of elements. I also, there's sort of elements of kind of compulsive type behavior of sort of checking plugs, checking doors are shut, things like that, that I'll do routinely normally, but I'll start to find that I'm going back round and doing it again. And that's often for me a red flag of, ooh, okay, where's my mind at right now? Yeah, those are generally the sorts of things.
Yeah, really helpful, and thanks for sharing those with us. So a move to Wales, so a new place, as you said, new sort of social situations, new friends, and the opportunity and the challenges that come with all of that. A new GP, I suppose, as well. Yeah, so lots of different relationships. What was it when you came to HHP, I suppose, that struck you as a service that was beneficial?
So a number of things. It was sort of coincidental that at the time I was reaching out for help was the time when COVID was emerging and everything was moving virtual anyway. So at the point that I first phoned and requested support, the call handler that I spoke to, or the person that triaged it, sort of said, well, actually, a lot of things are moving online at the moment. So rather than me searching for a therapist near your area, which is probably not going to be that convenient for you anyway, there's actually one in Cardiff that, if you're happy to do sort of virtual face-to-face online consultations, that would work well. And I thought, yeah, great, it works well for me. Meant I could access it from the comfort of my own home. And it was very flexible. And actually, I think in particular, I remember at the time being very mindful of the fact that I was about to start in psychiatry. I would be working, I wasn't sure who I'd be working with, but I knew I'd probably be meeting psychologists and the various members of the department. And I was nervous of being referred in as a patient at the same time as starting there as a healthcare professional. And so the idea of being able to engage with a therapist in a completely different part of the country was actually a big relief, because it meant I knew I could really keep anonymous in that sense, and really kind of keep my personal and professional identity separate, which was something that I was nervous about. So I was very fortunate with the sort of the timing in that sense. And I didn't feel that, sort of having had counselling and therapy and things before, I didn't feel that doing it online was any different really than doing it face to face. I didn't feel any disadvantage. So I feel very lucky that I was able to access such high quality face to face therapy, despite living quite far away from everyone.
Thanks, Natalie. I think really important to hear and to recognise the opportunities of virtual therapy and the transition that we've all had to make, as we were discussing before, and really glad to hear about the security, I suppose, that sort of the confidentiality of the service can bring. So thanks for sharing that with us. If you were to share with people who are listening today some of your reflections as to more generally about, I suppose, seeking help around mental illness, is there anything that would come to mind particularly?
Yeah, I suppose it's difficult, isn't it? And I think we were talking before about the various online groups and things that a lot of doctors access, and I see a lot of people posting anonymously on there, struggling and not really knowing where to start. And over the past 10 years, I've accessed help through a number of different routes. I've been through my occupational health department at one point. I'm aware, I haven't accessed them myself, but I'm aware that various unions and sort of various membership things that we have to be part of do offer sources of support. So if you want to avoid doing it through your own hospital, I think that's one way of doing it. So I think there are quite a lot of different avenues. It's just knowing where to start. And I think sometimes when you're struggling and feeling overwhelmed, actually taking that step and reaching out can be really hard. But there are so many different ways you can do it, whether it's going through your occupational health department, going through your own GP, self-referring online, going through a union. That there's so many different routes.
Natalie, I think that's again really helpful for us to just broaden our minds and think about the various different ways and how we should be really trying to support people through whatever route, if you like, they feel most comfortable with at the time that is there for them. But hopefully this and other events will hopefully make sure that HHP Wales is on the list of things that people at least know about. So thank you very much for talking to us today. A big thank you from me, but also thank you from everybody else who will be listening. And I hope you have a nice afternoon.
Thank you, you too.
So it's my opportunity again to say thank you to Natalie, particularly for sharing her experiences with us as well. I believe Sarah and Natalie are both hoping to join us for the question and answers a little bit later. So if there are particular questions, then perhaps we can pick those up then. Just briefly then, we've had the opportunity to reflect on the experiences that really ground HHP Wales as a service in the reality of these experiences of individuals, and it's our privilege to be able to help. Also recognising through the stories we've heard about the importance of our GPs, our occupational health services, our friends and our families, and the other support structures that are around us. Particularly, I suppose, I want to highlight the breadth of the HHP Wales service as it exists now, as we've heard from Jake earlier today, and some of the positive reflections around virtual therapy, and to just re-emphasize the confidentiality of the service as being something that we hold core and believe is extremely important in supporting people who may, for other reasons and various reasons, be challenged about disclosing some of their challenges and situations to other organisations. Just a couple of, just to note there in the Q&A, just a couple of positive reflections and thanks back to both Sarah and Natalie. So just to pass those on to you, and thank you very much again. We move on in our programme then to ask Julie Highfield to come and present to us. So thank you for joining us this afternoon, Julie. Just a brief introduction from me, which doesn't really do Julie's work justice, but to recognise Julie as being a consultant clinical psychologist who works to provide support in critical care in University Hospital of Wales, and that's to both patients and to staff, and recognising the importance of both of those groups in your workload, Julie, but has also been recently invited to lead in the Intensive Care Society's wellbeing project across the whole of the UK. And so really it's our privilege to welcome you this afternoon, Julie, to talk to us about grief and loss and your particular thoughts around how we might manage that. So over to you, and we'll manage any questions that come up, and hopefully we can be inspired to learn about what you can tell us. So thanks very much, Julie.
Thank you, Thomas. Right, I'll start sharing my screen with you. Okay. So thank you for that introduction. Yes, so I'm local to Thomas. I'm in Cardiff, and I've been working in both adult and paediatric ICU for 6 years now. Before that, I worked in a number of different medical settings as a clinical psychologist, usually previously helping patients and families, but this role I've had for the last 6 years has had that staff wellbeing element in it, and then 2020 has really challenged our staff wellbeing needs, as you can imagine. And one of the positives for me to come out of being in a pandemic is, of course, I was offered a secondment to help with the Intensive Care Society's WARE project, as Wellbeing and Resilience Through Education. So I'm their National Wellbeing Project Director for the Wellbeing wing of that project. So on to my presentation about grief and loss. I was struck by just the power and the honesty of those two stories. And actually, as I sat listening to you, I was thinking to myself, what are the things that I have lost this year? And I'm going to bring a little elements of my story in just to help the audience connect with what I'm saying. Very early on in the pandemic, a colleague shared this, I think on LinkedIn. It's a random thing to, people don't use LinkedIn an awful lot. And it was just the headline of that discomfort you're feeling is grief was just such a useful and powerful idea, really, a metaphor that actually there is so much that we have lost this year, and losses in such unusual and incredible ways. I think, you know, there's something to be thinking about in terms of the temporary versus the permanent loss. Obviously, the permanent loss is through death of so many people through COVID-19, and some of us have been unlucky enough that that's affected us directly in terms of our loved ones, directly in terms of our colleagues, and certainly clinically in terms of our patients. But there's also been a lot of temporary losses that I'm going to talk through as well. There's also something about thinking about one of the positives of this pandemic is the collective grief, the grief that we hold together versus individual stories in that. And what's really interesting for me is the social psychology of how that has shifted and changed. Now, I'll kind of talk about this sort of the energies and then the kind of loss of energies as I go along. And then the idea of a living loss, or what is sometimes called an ambiguous grief. And I was delighted to say that, to see that this was actually on the most recent episode or a week ago on All in the Mind, actually, but they don't talk about it in terms of the pandemic. So I thought, well, that's good. They haven't trumped me there. But ambiguous loss and ambiguous grief that we would normally think about is where we've lost something, but we're not absolutely certain in it. So it's very typical in, say, things like being the carer of your partner know that they have dementia, or having a child go missing, but the body is never found. And there's something about that not quite knowing where the point of your grief can start and not quite having that permission to grieve that is so common in so many of the losses that we're experiencing in 2020. So what have we lost? I think it's absolutely clear to say that the biggest thing that many of us have lost is a loss of freedom, and you know, it's certainly on that kind of day-to-day basis of our lives changing, and that sense of when will they return to normal. But one of the staff members who sees me came to me and he said, I just have a sense of impending doom, that this is the beginning of the next big end, which is rather dramatic. But there's this sense that will the world ever really recover from this? And the world has changed. Will it ever be the same? And of course, the world changes every day and moves on every day. But there is something in a shift of this. And I'm going to shamelessly quote the awful, dreadful phrases of 2020. And the new normal is one of those awful, dreadful phrases of this idea that this is what we're living now, and your old normal has gone. We don't know that you will ever get it back, but certainly for now, you are living in the new normal. And of course, a big thing that we're all dealing with in the constant sense of anxiety is our loss of certainty. There are, I guess our body is incredibly well trained to deal with the sense that something wicked this way comes, and actually we've all found ourselves in a sort of sense of hyper alertness and kind of dealing with that uncertainty, and being in that threat activation mode. But what's particularly interesting in terms of that sustained threat mode is it takes us away from our compassion mode, and it kind of over time it threatens to disintegrate our pro-social behavior, and you only have to look at the news to see that. So in this loss of certainty and this constant threat, there are other losses that come, and this idea, the anticipatory grief idea of kind of anticipating losing even more. Coming down into more kind of the NHS employers that we have around us, I think, you know, I can relate to this myself in terms of that loss of job related identity, and I'm sure I had a quick look through to the names that I would recognize in the participants list, and I'm sure there's many people who can relate to this idea that, you know, at the beginning of all of this, we were headless chickens in chaos. And staff were being pushed left, right and centre for very good reason in anticipation of that giant peak. But so many people got lost in the chaos. I certainly was one of them. I lost my office and was pushed off the unit, and I lost that sense of connection and what does the unit want from me. I, over time, have talked to colleagues who have found that their role has been kind of reshaped and crushed and morphed. You know, I'm lucky in a way that I also gained in terms of my own personal job related identity, but I'm so aware of so many things shifting and changing, and so many things still feeling very uncertain for people, and just thinking about so many people that I've seen at that kind of trainee doctor level, where there's delays in training and exams. I think that's the same for, you know, beyond our kind of school children and kind of university children, but certainly also in junior band 5 staff, this sense of, well, actually, what about my career progression? What's going to happen now? And shifting sense of kind of employer expectations. What is my purpose, and how can I be useful in this? And I note a huge number of people feeling quietly angry and resentful of that, and then turning that anger and resentment in on themselves, because in the chaos there is no system necessarily for being heard, and venting that. And then, of course, the idea of loss of what we deliver. So what you see on the right-hand side is what's called the humanisation of the critical care unit. And I would describe the pandemic as the dehumanisation of critical care. And I'm sure there's lots of people in lots of other health environments that feel like that is happening too. So we losing from that previous slide that sense of accomplishment and identity, but also what we're witnessing is that fairness and lack of fairness in healthcare. And spent a lot of time sitting at distance with my elderly neighbour in my garden, kind of chatting about what healthcare she was missing out on whilst we focused on everyone else. And of course, linking to Neil's talk about that moral distress, it's our threat of integrity here. It's our inability to deliver at the level of which we would like to deliver, because the situation is as it is. And then, incredibly importantly for me, but I don't think I quite realized it quite as much until a few months into this pandemic, is that loss of connection. And obviously, as the photo entails, you know, it's very hard to see your colleague when they're in PPE. But even if you're just wearing your face mask in a meeting, someone turned around to me and said, I think you're smiling. I'm just going to assume it's a smile under that mask. And, you know, one of the things I miss the most is the casual social smile in the corridor, and that time to connect, but also that informal connection has been lost in us through the use of PPE and wider society of kind of social distancing, and not being able to travel and all of those other things. And I quite, I don't think I quite realized it quite as much until a few months into this pandemic, is that loss of connection. And obviously, as the photo entails, you know, it's very hard to see your colleague when they're in PPE. But even if you're just wearing your face mask in a meeting, someone turned around to me and said, I think you're smiling. I'm just going to assume it's a smile under that mask. And, you know, one of the things I miss the most is the casual social smile in the corridor, and that time to connect, but also that informal connection has been lost in us through the use of PPE and wider society of kind of social distancing, and not being able to travel and all of those other things. I think most importantly, that loss of energy to keep going. One of the things that I did, which I would describe as the worst week of my life, actually, but I led on one of the British Psychological Society's first responses to the pandemic, which was about almost predicting what healthcare staff would go through, and DAF told us we predicted a recovery phase. I think we were very optimistic we might see it in 2020, but what we predicted, and I think is hugely important, is this idea of phasing from that early active to core active, from the heroics to the disillusionment. And I'm actually quoting myself from a teaching I did this morning, and it went down well, because someone said to me, why can't we grasp the energy of snow days? Because everyone had such heroics at the start. And one of the things I said on the teaching this morning is we started with the same energy you'd have on a snow day. We didn't realize we would end up moving to Alaska. And I think that initial surge of innovation and energy and enthusiasm is now wiped out with exhaustion and disillusionment, and we've lost our sense of our energy and drive. So how to be practical about this? How shall we mourn our losses? Well, we should mourn. We should mourn. I think, you know, it's quite important thinking about absolute death and grieving here, and I've supported a number of staff members who have lost loved ones during this year. There are key things about, you know, grief allows us to retreat, to kind of sit in the corner of our cave and lick our wounds, as it were, but it's so important that we reach out and stay connected. However, it is also important to take that time for yourself and just allow the passage of time to retreat, and allow yourself that comfort, allow the emotions to flow. And we have an idea in psychology that we call the tasks of grieving, which is allowing yourself to actively remember. So I will work with someone to encourage them to listen to the music of their loved one, look at photos, tell the stories. And of course, the really important thing in this pandemic is we have lost some of our symbolic endings. So we have to find different ways of finding our symbolic endings. I think we think about the kind of Kubler-Ross kind of model and grieving in ambiguous loss, and the absolute kind of start of that is it really is okay to name this and hold this, and it is okay to not be okay. We can go through those phases with this virus of denial if the virus won't affect us, of anger at staying home and taking away activities, and the surge of what's required of us in the NHS, that bargaining of, okay, I'll do this for a bit and then it will be better. And then there's sadness that we're in right now, where although we have a vaccine and there's some light at the end of the tunnel, we still don't know when this will end. I guess just as an alternative to Kubler-Ross, a grief counsellor about 15 years ago shared this model with me, and then, you know, years later I came to work in paediatric critical care, and I realised that Papadatu is a Greek psychologist who works in paediatric critical care, and she was trying to help staff come up with a different model of grief, and in terms of cumulative grief and loss that we experience at work. And the idea, if you look at it, how I use this all the time in my clinical work, we run two versions of ourselves in parallel when we're experiencing loss within the context of our work. So we have on the left-hand side the part of us that will allow ourselves to connect with the grief. And then on the right-hand side, the kind of, sadly sometimes called the man up culture, but the brave face work mask culture of avoiding and repressing and getting on with it. And we find that we kind of flip-flap back and forth, and that's that zigzag across the middle, and our own particular lifestyle and the culture of work, the work style are the two boxes kind of feeding in to that process. And I think that that's also, I find that a more useful model of grief rather than stages for healthcare workers, that flip-flapping between I'm grieving, I'm not, I'm grieving, I'm not, I'm grieving, I'm not. But there are other more practical things that we need. And this threat activation, in this sadness and loss, we need soothing and comfort. I'm a big fan of the Danish hygge. I'm loving this time of year for blankets and candles. But what we really need is that parasympathetic nervous system activation. We need to come down from this nervous energy that we're all experiencing right now, and we need this soothing and comfort. The nervous energy someone described to me recently as frantic boredom. And we need that time for soothing and comfort. Another way it was described to me recently is Netflix and Pringles. We need that time. We also need to be very aware of the tricksy nature of our brains and our tendency to try and kind of think ahead and catastrophize. And this is where, you know, people who favor the concept of mindfulness is kind of helpful, not for everyone, but the idea of here and now thinking and dealing with what we're experiencing as it is right now is important. And I think for me, I find that kind of almost that sense of kind of trying to say, what can I do today? What gets me through today? Just because the surge of work that I've personally had to experience at times has pushed me right to the edge. And I'm not afraid to tell you that I have both screamed and cried at my desk. Lucky for me, I'm in an office where no one else is around, and I can do that freely without judgment. I guess linking on from that, this is something I used to hate, I have to say. And I know my colleague who loves this is definitely in the participants list. But I have to say to you, Claire, 2020 has made me embrace the circle of control. And I think it works really, really well in terms of how we deal with what we're facing and what we're struggling with right now, which is what is within my immediate control. What are the things that I can do versus the kind of the wider things that feel beyond us. The pandemic is beyond us. We are, you know, it's even beyond most of the people who are in charge. So what can I do right now? How can I set limits on that catastrophizing and deal with the here and now within my circle of control? And, you know, one of the ways in which I have done that, and this is a top tip that I've used in almost every single member of staff that has come to see me, and now, just to give you an idea, 70 members of staff have come to me so far since March for help and support. And this is my #1 top tip that I keep coming back to. It links to the ambiguous loss. This is so big and so hard to work out when it will end that we have to set artificial milestones to help our primitive brain cope. So I absolutely, for me, my first milestone was the end of the first 12 weeks and looking at when shielding staff would go back as that first kind of, well, I know it's going to last at least until then. Then you have that arbitrary milestone. I think Christmas is a perfect, people might not describe it as arbitrary, but it's a milestone. And I think we've got so many people who are saying, I'm limping up until Christmas. If I could just get through Christmas, then my brain can prepare for the next part. And I think actually public health have been particularly good at doing this, whether it was their intention or not. But you do have the sense of the vaccination now and the sense of what will happen at Easter. And so many people are saying to me, I'm getting to April now. April is my target, which of course will take us to a full 12 months. And then where we can, I think, you know, for me, I've actually fully embraced the Zoom, and I love the Zoom at work. After this evening, I have, I think, my 4th social Zoom of this year. So one of the things that's been incredibly hard is almost that Zoom fatigue, and using that as a social mechanism. And I think it's so hard for us when we're in healthcare and we're on this all the time, to have the energy to connect socially. But this is kind of us coming out of our caves and realizing the me too of all of this. One of the fantastic things for me, certainly when I got my office back in September, and I could just walk the corridors again, in a very different way, and not be out on a limb in a kind of old building, was the Me Too conversations that, oh, this has been tough on you too. And that social connection has been so important in this. And then another blatant, awful phrase of 2020, it is what it is. The fifth stage, if you come back to the Kubler-Ross model, is about acceptance. And I would say name and claim your grief, recognize it for yourself, recognize what is happening. And it's only then when you recognize this as grief that you will figure out how to proceed next. And then finally, Kessler added kind of post-mortem to Kubler-Ross's model, the idea of finding meaning. And I think within all of this, we have to find our own personal sense of meaning with this. It has to mean something to us, and whether that's your fantastic skills in soda bread making, or whether that's because you've contributed to the PPE cell, or you've written the IP&C SOP for this. Find your own meaning, find your own purpose in this, and keep searching that out in every part of this grief. And finally, just to say thank you for listening to me today, and thank you so much to Thomas and the team for inviting me to speak.
Well, Julie, thank you very much. Really interesting to listen to. I've certainly written a few things down myself, so thank you very much. We are moving on generally to questions from the end of here. So, but just before we move on to sort of general questions and give people time to write anything if they wanted to ask anything from the rest of the sessions, I was, I suppose, taken by this idea of the challenge that threat poses to compassion. And how grief can come into that stage, and just reflecting back, I suppose, on something that Sarah said about recognizing the importance of kindness in the workplace, and how actually once there's more of a statement here, I suppose, but interested to hear your thoughts around when we're in that state of grief or loss or challenged, and I guess we've been in that more often than we would perhaps admit over the last few weeks and months, then the challenge that faces to compassion is obviously high by what you've said. And so the kindness is then the thing that perhaps gets challenged, and maybe we've seen that in some of the activities and actions of our colleagues and even patients. And I think taking a moment to reflect on that for me is quite an interesting concept to think about.
Absolutely. I guess what I would say is when people say just be kind, I think those people don't understand the complexity behind it. We're all capable of being kind and compassionate, and we're all capable of being unkind and dispassionate, actually. And I guess one thing I would say is think about collective compassion. It's a bit like a book I read by Will Self years ago, The Quantity Theory of Insanity, this idea that we kind of share it out amongst ourselves and one person comes up and the other person comes down. I think we need the quantity theory of compassion. Actually, some of us will hold it while others are wavering. Those people will come back to us and we will waver and need them.
taking it to a team level is that's interesting, isn't it? Or when I say team, a group level is that again raises it even further. And just, I suppose, another reflection from me, you had Maslach's sort of hierarchy of needs there at the end, and I'd never, given that we live in a very easy place in many respects to live in here in the UK, I'd never really appreciated some of the base elements of Maslach's sort of hierarchy of needs, and clean air to breathe, and the first time you put on that FFP3 mask or any other mask really, and actually it does change our concepts of what we need and the essential things to our existence. So
absolutely,
thank you again, Julie. I'm very keen to sort of pick up on some of the other questions that have come up in the day, but from our perspective here at HHP Wales, thank you for your work and for sharing what's been a very helpful session this afternoon. And I hope, I suppose my challenge to everybody is to take away something from Julie's session that she's mentioned, and try and put it into practice, because I guess that's the somewhat of the difficult part, is to whether it be the circle of control, or I'm just reading the things I've written down here about here and now thinking, or staying connected, and how we do that. Then the challenge to us is to do some of those things in reality. So, and as you said, some of those will come and some of those will be more difficult, and that will change over time. So brilliant. Thank you very much, Julie. We'll just appreciate, we've got a few minutes before we said we were going to finish here, but just recognising there's a question that came up twice, I suppose, in the chat earlier through the day about how we link with the student professional support unit. I just wanted to reflect back to the group of people that are still here that yes, we are in constant, almost kind of conversation with HEIW, and very, very keen to work with the trainees. In terms of medical students, then we're linked in very much with MyMedic, which is the support services for the medical students here in Cardiff. Keen to develop support structures for the other student groups, actually, in that they're less well developed, although we have had some students from nursing come through to us so far, and dentistry, in fact. So that's those. I've lost my little bit here in the chat. There was a question I wondered if Jon, you wanted would be happy to answer for us, which is reflecting on the trajectory of referrals to HHP Wales. So the question is, given the referral trend to date, what referral trajectory is HHP on for 2021? And this, I guess, links a bit to what you said, Julie, about the phases of recovery that we had potentially thought about 6 months ago, but actually, on reflection, maybe the timescales are slightly different now. But Jon, in terms of trajectory referrals.
It's a really interesting question, Thomas, and as you know, it's one that we've had several discussions about, and planning for how many people you're going to see has been a very, very tricky issue. At the moment, we're kind of thinking that we would expect our referrals to double over the next year. That's the kind of rough sort of back of an envelope, if you like, sort of figure that we're thinking about at the moment. We've been working very closely with Welsh Government, who've been very supportive with this, and the fact that we can't predict accurately, and trying to set up our system in a way whereby we have some reserve capacity, if you like, so that we can actually expand according to need. And so therefore, the cost would be what we're actually using, rather than, sort of having a capacity that isn't used. I think the jury's still out, if I'm absolutely honest. I think it's been spoken about in the chat. We're hoping to launch our new website shortly, and Jake mentioned it earlier on. We're hoping that will be accompanied, well, it will be accompanied by a bit of a campaign to raise awareness, which we clearly need to do. And that's where we think we're going to see a significant increase in our numbers. Another question I noted earlier on was, why are numbers increasing? Is it because of COVID-19 or is it not? And again, I think that's an empirical question. We don't know what the answer is at the moment, but I think what we do know from Julie's and others, observations and experiences is that we are seeing NHS staff being affected and stressed by, by the pandemic. If I can just make one more point, which is just that, and it comes out from the chat, I think, that HHP Wales is one form of support that is available to health professionals and people working in the NHS. We're open to any member of the NHS staff, but there are other opportunities, going to see your GP, in some services, seeing somebody like Julie, for example. I mean, 70 people is a lot of people, Julie, in that space of time. And also occupational health, and we've heard about the professional support unit at HEIW. What we want to be is one part of a variety, of portfolio of different services and avenues that people can get support from. And we're very aware that one won't suit everybody. And I think it's really important that people can access different things according to their needs. Thanks, Thomas.
Thank you, John. Yeah. Thank you for sharing what we're hoping to see, and also highlight the work that we know we've got to do around promotion of HHP Wales, and particularly getting it to the non sort of hospital based kind of healthcare workers is also important to us, and recognising the breadth of services that are available. I think Julie and I have spoken about this already. We saw a very big sort of explosion of work around well-being and healthcare support as the pandemic sort of occurred and became real to everybody, and recognising that in all of that work, then some of that was quite hard to sift out quite what was suitable for some people and what was suitable for others, what was available to some and available to others, and we as HHP had our challenges through that as well. And then now we're left with a different agenda, which is recognising that well-being and supporting healthcare staff is starting to fall down some of the agendas on our executive teams across different health boards, and the challenge to us is to try and keep it there for the well-being of the staff moving forwards. Anybody else wants to comment or add to that about what we might expect in the next few weeks and months?
Can I maybe make a comment? Just what I've heard a lot from staff lately is, I don't know what I feel yet. And I wonder if actually it's the lag. I'm a bit different because I'm on site, I'm back as well, which also helps. Being slightly more removed, I think, has massive advantage, but I think there's almost some people who are limping on, not quite realizing where they're at yet. And I think for me, coming to the two personal stories of the power of what happens when you get the timing right and you realize for yourself you need that help and support, and how helpful that can be. So I would be with you, John. It wouldn't surprise me if this time next year, if you compared your numbers, you see that time delay lag and your surge.
Yeah, I think that's a really good point, Julie. And what's known through the sort of the work in the traumatic stress field is that actually different people have very different trajectories in terms of their own personal responses. So some people will be distressed straight away, perhaps, and then have a gradual reduction. Others will start off without any apparent distress and go up. And there's people in the middle, and people who go up and down, and people who don't seem to react at all. So I think it's really important that we look at everybody personally as an individual. And, as you said, it's absolutely all right to feel how you feel, and we should recognise how we're feeling. And if sort of 2 years on, something suddenly hits us, that's the time to go and seek help at that point. Don't think that it's 2 years and I shouldn't be going to seek help. So no, I agree. That's a really good point.
Thank you very much, everybody. There's a couple of specific questions that have come up that I think we can probably get back to some of the individuals directly to, if that's okay. Catherine will definitely get back to you specifically about our recruitment of psychologists and therapists as we go forwards. Just to reflect as we move through, so there's a question here about medical student contacts and the issues raised. We have seen quite a lot of medical students come through to the service, despite the My Medic service being in existence, and that recognises the different scope that we as a service can provide for medical students. And from speaking to one of our colleagues who manages that service, a lot of that has been around anxieties, around uncertainty, many of the things that Julie has talked about, loss of networks, and coming back into situations where, as it were, sorry to use the phrase, Julie, the new normal is not what was expected or anything close to the experience that was desired. So very happy to put you in contact if you would like to, whoever's asked that question, directly with that service, if that would be helpful to your practice. And then just lastly here, a message from Sally. Many thanks coming up in the chat, but specifically a thank you from Sally about the accounts from Sarah and Natalie. So thank you again to both of you for being courageous and sharing those with us. It's important for us to recognise how important that is, not just to us as a service, but also normalising the challenges that mental health is or creates for all of us. And we're very grateful to you. Lastly then, I'd like to say thank you very much to everybody that's joined and been with us all afternoon. Hopefully it's, again, raised some awareness, not just of our service, but of the complexities that we're living through. Thank you very much. We'll be prepared to stay around for a little bit longer if there are specific questions that people would like to raise, but thank you to everybody who's spoken, and thank you to Jon for chairing the first session, I hope everybody has a lovely afternoon of what's left of it, and maybe you have some social Zoom activities for the weekend, and if not, enjoy the face-to-face contact that we can have with the people that we live with. Jon, was there anything else you wanted to close with?
Well, no, just a big thank you. I mean, a big thank you to you, Thomas, as well, for chairing this session and for everything that you do for HHP Wales, to our external speakers, to Julie and Neil for coming along and speaking, of course, to Frank for giving his bit. And again, you know, I'd really like to reiterate what's been said already to Sarah and Natalie. You know, I mean, I think it's great that you were willing, and we're really, really grateful that you're willing to give us your accounts. One final thing is that we have been recording, and we are hoping to be able to share at least some of the content with you. So, you know, we will get in contact about that after the session. But yeah, just a big thank you, and enjoy the rest of the day. And I hope everybody has a break over the festive season.